Hello and welcome to today's Center for Healthcare Strategies webinar made possible by the Robert Wood Johnson Foundation on implementing trauma-informed care in pediatric and adult primary care settings. This webinar is the first of a two-part series on putting trauma-informed care into practice. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following each of the presentations. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you'll take a moment to do this. I'll now turn the webinar over to Christopher Menschner, Senior Program Officer at the Center for Healthcare Strategies.
Thank you, Travis. Good afternoon, everyone. As Travis mentioned, my name is Chris Menschner, and I have the privilege of serving as the Deputy Director of CHCS's Advancing Trauma-Informed Care Initiative. We're delighted to welcome you to today's webinar, the first in a two-part series on implementing practical strategies for trauma-informed care at the primary care as well as the health system and organizational level. As Travis mentioned, the webinar series is made possible by the Robert Wood Johnson Foundation, which is supporting CHCS's work in advancing trauma-informed care. This national initiative is aimed at understanding how trauma-informed approaches can be practically implemented across the healthcare sector. We are working with 6 demonstration sites in diverse care settings across the U.S. to develop capacity and best practices for delivering trauma-informed care. The sites include the Center for Youth Wellness in San Francisco, the Greater Newark Healthcare Coalition in Newark, New Jersey, the Montefiore Medical Group in the Bronx, New York, the San Francisco Department of Public Health, the Stephen and Sandra Scheller 11th Street Family Health Services in Philadelphia, and the Women's HIV Program at the University of California, San Francisco. Today you'll hear from 2 of our advancing trauma-informed care sites, but first I'll go over the objectives for today's webinar. I'll also give a brief 101 overview on the impact of trauma and the value of trauma-informed care. Our hope is that by participating in today's webinar, you'll learn how 2 leading healthcare organizations are utilizing trauma-informed primary care approaches to serve patients' complex health and social needs. And then you'll also come away with practical ideas on how to implement a trauma-informed approach in your own settings or health systems. While there is no universal definition of trauma, it is generally recognized as exposure to adverse experiences. Much of the focus on trauma and its impact started with research on adverse childhood experiences, commonly referred to as ACEs. The pivotal ACEs study done in 1998 by Vincent Felitti at Kaiser Permanente and Robert Anda at the CDC was the first research to demonstrate that childhood trauma is far more common than previously acknowledged and has deeply negative effects on health outcomes. As a result, ACEs screening tools are now often used to identify histories of adverse childhood experiences in patients. Why? Because there is a direct correlation between ACEs and health outcomes. Individuals with high ACE scores, typically 4 or more, have greater potential for adverse health outcomes. But oftentimes in the primary care or large health system environment, past trauma and ACEs scores don't readily rise to the surface. That's where trauma-informed care comes in. Trauma-informed care takes the patient's experience of trauma into account and changes the approach from what's wrong with you to what happened to you. Trauma-informed care helps to build both patient and staff resilience and should include both clinical and organizational components. From the security guard at the front door to the receptionist to clinicians, all staff members should be involved in trauma-informed care efforts. Through interviews with leading trauma-informed care experts across the country and our work with the Advancing Trauma-Informed Care demonstration sites, we've identified key organizational and clinical ingredients that ideally must be in place to provide trauma-informed care. Lastly, a trauma-informed approach should be based on a set of core principles which place a priority on patient empowerment, choice, collaboration, safety, and trust. As I mentioned a second ago, you'll be hearing from speakers who lead 2 of our Advancing Trauma-Informed Care demonstration sites today. Our first speaker is Dr. Nadine Burke-Harris. Dr. Burke-Harris is the founder and CEO of the Center for Youth Wellness. She is internationally recognized for her innovative approach to addressing adverse childhood experiences as a risk factor for adult diseases such as heart disease and cancer. Her work has demonstrated that it's time to reassess the relationship between poverty, child development, and health, and how the practical applications of the Adverse Childhood Experiences study can improve health outcomes. Our second speaker today is Dr. Eddie Mochtinger. Eddie is a national thought leader and advocate for education and policy pertaining to trauma-informed care and women's health. Eddie is a professor of medicine and director of the Women's HIV Program at the University of California, San Francisco. Much of his work is focused on developing, implementing, and evaluating a scalable model of trauma-informed primary care. At this point, I will turn it over to our first speaker, Dr. Nadine Burke-Harris.
Thank you so much. I want to start by thanking CHCS and also the Robert Wood Johnson Foundation for supporting this important work. So I'll start by talking a bit about how we as a Center for Youth Wellness in partnership with the Bayview Child Health Center use the framework and the science behind adverse childhood experiences and toxic stress to improve patient care. So as we heard previously, we understand the original Kaiser CDC ACE study looked at these 10 categories of adverse childhood experiences, which include physical, emotional, and sexual abuse, physical and emotional neglect, growing up in a household where a parent was mentally ill, substance dependent, incarcerated, where there was domestic violence or parental separation or divorce. And what we learned from that study when Felitti and Anda looked at these questions among 17,500 Kaiser patients were two really critical things. One is that ACEs are incredibly common. So 2/3 of their population had experienced at least one adverse childhood experience, and 1 in 8, 12.6%, had 4 or more adverse childhood experiences. We know that this ACE data has been now looked at all across the country. Here in California, as part of our behavioral risk factor surveillance data, what we found was that, and it was actually to my surprise, was that the prevalence of the 10 traditional ACEs was very similar among the ethnic groups in California. So we see this as something that has a high prevalence. It's really common among all ethnic groups. We saw that among Caucasians and African Americans, it was about a little over 16% who had 4 or more ACEs. With the highest in California being among the Hispanic or Latino population, with 17.3% experiencing 4 or more ACEs. Nationally, this data is, what we see is that, you know, there's no state, community, neighborhood that is spared. In fact, we know the original adverse childhood experiences study was done at Kaiser San Diego in a population that was 70% Caucasian, 70% college educated, right? And this data is from the National Child Health Survey, or the National Survey of Children's Health, where we see that across the nation, there are more than 34.8 million children who are currently experiencing adverse childhood experiences. The second thing that Felitti and Anda found was that in addition to that ACEs are extremely common, there was a dose-response relationship between adverse childhood experiences and health outcomes. So the higher your ACE score, the worse your health outcomes. I've listed here the 10 leading causes of death in the United States of America, and what we see is that for individuals with 4 or more adverse childhood experiences, they have double the risk of heart disease, more than twice the risk of cancer, 3 times the risk of COPD, 2.5 times the risk of stroke, 11 times the risk of Alzheimer's, 1.5 times the risk of diabetes, and 30 times the risk of suicide. Now, this data is actually not from the original Kaiser CDC study. This This data comes from the global data that was published this year, 2017, looking at ACEs across more than 20 countries around the world, so that we see that in addition to being a health crisis in the United States, this is in fact a global health crisis. But the original ACE study, one of the really interesting things about it was that it looked at the association between early adversity and adult health outcomes, because they looked at it in adult population. Well, since that time, our organization, the Center for Youth Wellness, has looked at how adverse childhood experiences affect the health and well-being of children. And what we found was that as early as infancy, childhood adversity is associated with recognizable symptoms, including developmental delay, growth delay, and failure to thrive. In young childhood, we see increased risk of asthma, pneumonia, viral infection, atopic diseases like eczema and allergies, increased learning difficulties and behavior problems. And in addition, in adolescence, we see increased risk of obesity, diabetes, headache, abdominal pain, teen pregnancy, and I listed hyperthyroidism there, but it's actually increased risk of autoimmune disorders and also changes to pubertal timing. So there are many things that for myself as a primary care pediatrician, there are many ways in which it's really important for me to recognize the impact of adverse childhood experiences on the health and well-being of my patients. And when we're trying to understand what do we do about this issue, it's really important for us to understand the biology of adversity. So just like with HIV, when we understand that the disease was caused, you know, doctors were seeing patients come into the hospital and they had, you know, tuberculosis, or they had, you know, this weird skin cancer called Kaposi sarcoma, or they had a weird pneumonia, you know, very rare pneumonia. It was one thing for doctors to get good at treating the tuberculosis and the pneumonia and the skin cancer, but ultimately we had to understand what the underlying biology was, which was an infection compromising the entire immune system, for us to be able to make substantial headway in the treatment of HIV and AIDS. And so understanding how early adversity affects children's developing brains and bodies is critically important. And the good news is that over the past 2 decades, an understanding of the science has really advanced, right? So now we know that what we see in children who have been exposed to early adversity is that we see this dysregulation of, you know, I have all these, you know, medical terminologies in here because I'm often speaking to doctors, but dysregulation of the HPA and SAM axes. That's our fight or flight response, right? That's what makes adrenaline and cortisol in our body. And that leads to overactivity and difficulty turning off the stress response. We see activation of the amygdala, which leads to increased fear responses, inhibition of the prefrontal cortex, which leads to impaired executive functioning, toxicity of the hippocampus, which leads to difficulty in learning and memory, and changes to what we call the VTA, the ventral tegmental area, and the nucleus accumbens. That's a part of the brain that is our brain's pleasure center. And when that area is dysregulated, what we see is that individuals get less pleasure from activities that should be pleasurable. And so they need higher and higher doses of these things like cigarettes or alcohol or cocaine or methamphetamine, to feel the same amount or to get that pleasurable response. And what we see is that dysregulation in this part of the brain is associated with a dramatically increased risk of substance dependence and other high-risk behaviors. So it's important to know that there is a biological underpinning to some of what we see there. In addition, I think the impact of early adversity on children's developing brains is something that we hear a lot about, but it's important to understand that early adversity affects every developing system in a child's body, including their immune system, where we see increased markers of inflammation, and we can measure them: tumor necrosis factor alpha, interferon gamma, all of these markers of inflammation that we can see. But really what that means, as well as inhibition of the anti-inflammatory pathways and impairment of certain types of the immune system. But really what that means is that it translates into increased risk of viral infection, certain bacterial infections, and also chronic inflammation, right? And this chronic inflammation can happen throughout the lifetime. We also see changes in our hormonal systems with long-term changes to cortisol, adrenaline, and other hormones, inhibition of the thyroid, which regulates metabolism, and alterations in growth hormone and other hormones, which lead to changes in growth, development, metabolism, and puberty. All of these changes, the increased risk of inflammation, overactivity of the stress response, and changes to these long-term hormones also increase risk for our cardiovascular system, right? So that increased risk is seen in some of the hormones and the proteins that a damaged cardiovascular system produces. And finally, you know, as a pediatrician, one of the first questions when I was looking at this is, how is it that these changes last such a long time, right? How is it that early adversity can affect health outcomes long after someone has left the stressful or adverse environment that they've been in? And that has to do with our epigenetic regulation. When children are exposed to early adversity, it changes the way their DNA is read and transcribed. And that leads to long-term changes in the way that the brain and organ systems respond to stress if there's no intervention. And what we see as a result can be premature cell death, so cells that just don't do their job anymore, or altered cell replication that leads to increased risk of cancer. So we now understand that early life adversity can be buffered by protective factors, and there's a lot of science and research about how protective factors, so everything that I've talked about in terms of stress hormones and the activation of the neurologic stress response and changes to our DNA, we now understand that there are factors that can help to buffer that stress response. Things that include like safe, stable, and nurturing environments and relationships that are critical to interrupting this cycle. So we have protective factors. Now, some individuals will have predisposed vulnerability, and we know that early life adversity translates biologically into a chronic dysregulation of the neuroendocrine and immune system and changes to our genetic regulation. And this is what we now know as toxic stress. Now, the good news is that all of this science tells us that we can mitigate the impacts of ACEs with early identification and intervention. So at the Center for Youth Wellness, in partnership with the Baby Child Health Center, we have implemented a clinical protocol which includes screening, prompt intervention, enhancing protective factors, and appropriate treatment. So I'm going to talk a little bit about what that looks like. So this is an example of our screening tool. It includes the 10 original ACEs from Felitti and Anda, as well as other factors that we believe also activate the stress response and can dysregulate our neuroendocrine immune system. Things like losing a parent through deportation or migration, or medical trauma, or being treated badly because of race, sexual orientation, place of birth, disability, or religion. Now, because these items were not included in the original ACE study, we don't call them ACEs. We don't call them adverse childhood experiences because that refers to items from the research, from that study. But we do understand that they are additional risk factors for toxic stress. And we do, we have a child version that's completed by the caregiver, and that's the one you see in front of you. And then from 13 to 19, the child fills out their own version, the teen version, and the caregiver also does their version. And we actually use a de-identified screening tool, and part of the reason for that is to allow primary care clinicians to be able to screen for ACEs. And what we get in this is just a number in that box. We don't ask our patients to identify which ACEs, only how many, and that helps us assess their risk. So if a patient has 0 to 3 ACEs with no symptoms, so if a patient has 0 ACEs, they're considered low risk. Not no risk, but low risk. If a patient has 1 to 3 ACEs and no symptoms, they're considered intermediate risk, meaning they've been exposed, but they haven't manifested any symptoms yet. And if they have 1 to 3 ACEs with symptoms or 4 or more ACEs, they're considered high risk. And so for our high-risk patients, for our intermediate and low-risk patients, we do anticipatory guidance, tell them what to look out for and when there's a concern. And then for our high-risk patients, we do a multidisciplinary intervention, and I'm going to show a little bit what that looks like. So in this, I'll start with, I'll show that by talking a little bit about what this looks like with an actual patient. So this is one of my patients, 2-year, 9-month-old female who came to me for her regular physical. And her mom's only concern was that she was small, right? And she had a little bit of, intolerance of milk, but otherwise she was great, no complaints. When asked, do you have any concerns? She's like, no, she's a little small. I'm wondering, what's the deal? She wasn't tolerating milk very well, but she's on almond milk now. So this was a girl who was, born at full term, normal spontaneous vaginal delivery. Her birth weight was at the 25th percentile. She has a normal developmental history, but her growth history was she went from 25th percentile at height and weight to decreasing consistently until she was below the 3rd percentile for height, weight, and her body mass index. And her previous doctor said they just needed to offer her more nutrition and recommended Pediasure, which is a nutritional supplement. And mom and dad they're not gigantic, but they're not tiny. This is this child's growth chart. And we see that she started at the 50th percentile for length and the 25th percentile for weight. And as you look as the growth chart continues, she continues to decrease until she's below the 3rd percentile, right? So that dark gray area is below the 3rd percentile. I did her normal physical, her labs. I did a skeletal survey. I did a bone age, which is an X-ray of the wrist, to evaluate her skeletal maturity, and she did have a delayed bone age. But her developmental screening, her ages and stages questionnaire, her modified checklist for autism, they were all normal. But her ACE score was a 7+0. 7 on the traditional categories, 0 on the supplemental categories. So this was an almost 3-year-old girl who met the diagnostic criteria for failure to thrive, which meant she wasn't growing and gaining weight. But there's so many things that can cause failure to thrive. And after I did this workup looking at all her labs and all of these things, the ACE score was really the thing that pointed to the most likely diagnosis, which was it was most likely that she wasn't growing due to a toxic stress physiology, right? And so what we do at the Center for Youth Wellness is we have this integrative plan of care. We start by looking at the things that have been demonstrated to reverse, to help a toxic stress physiology, help the biology. which includes sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships. We went ahead and did the nutritional supplementation and referred her to WIC to make sure she could get that. But we also referred her to for the Center for Youth Wellness for child-parent psychotherapy. And in this case, we were able to do a warm handoff to introduce her to the clinician, to the clinician who would be working with her and her daughter. It started by education of the family about what was going on. And what I said to this mom was, I think because of what your daughter has experienced, her body may be making more stress hormones than it should. And this may be what's affecting her growth. I want to refer her to a specialist that can help you learn how to support her and reduce the amount of stress hormones that her body is making. We also know that a healthy caregiver is one of the most important ingredients for healthy children. So an important part of helping your daughter heal will involve managing your own stress level and practicing taking care of yourself. So we connected her to child-parent psychotherapy. We did the warm handoff in this case, but a referral with follow-up is more typical, right? We discussed with the treating clinician about what we thought was what was going on, and we had buy-in from the entire team, including mom, that in order to treat her daughter's poor growth, we were going to do this multidisciplinary approach. And what we saw, this is her growth, her actual growth chart. This child's body mass index went from way below the 3rd percentile to between the 10th and 25th percentile. And in this case, it's likely that the hormonal part of the toxic stress response was what we were seeing in terms of her symptomatology. But we recognize that there's currently not really diagnostic criteria for doctors to diagnose toxic stress. It's doing the ACE screen helps us identify patients who might be experiencing a toxic stress physiology and deliver more effective and more efficient care. So one of the important things here is before I did a whole workup of her metabolism, before I sent her to a geneticist or a neurologist, the ACE screen allowed me to do an intervention that was effective for this patient. Our treatment strategy involves reducing the dose of adversity, enhancing the ability of the caregiver to provide a safe, stable, and nurturing environment, as well as regulating her own biology, and the 2-generation nature for young kids, right, of child-parent psychotherapy was very important. And I just want to add this really interesting corollary. This patient's 9-month-old brother, who was not the index patient, he had had 3 ear infections and 2 pneumonias in his first year of life. According to mom, he was always sick. I referred him to ear, nose, and throat for an evaluation of his frequent ear infection. But after we started the child-parent psychotherapy intervention, he never had another ear infection. He never had another pneumonia, and mom noticed a dramatic decrease in the number of colds and upper respiratory infections that he had. So this is what we're doing at the Center for Youth Wellness and the Baby Child Health Center. We're really taking an integrated approach to caring for patients who have a history of adverse childhood experiences, particularly that is impacting their health. And then we're also learning how to do this with other clinicians. So we've launched the National Pediatric Practice Community on ACE screening, which is a virtual community with a focus on supporting early adopters, fostering partnerships and awareness, learning together about this emerging science, developing best practices, and spreading what works. So that's all I have for now, and thank you so much for your attention.
Thanks very much, Nadine. So at this point, we'll hold a 15-minute question-and-answer session with Nadine before we turn it over to our next presenter. Just so everybody knows, we'll also, of course, hold a 15-minute Q&A session with Dr. Mockninger, too, after his presentation. And just a reminder to everyone, in order to submit a question, please click the question mark icon located in the toolbar at the top of your screen. So our first question to Nadine, what is the most important thing for pediatric primary care providers to be aware of when speaking with patients and family members about trauma?
That's a great question. So, you know, my immediate answer to that, I think that understanding how early it's really important for pediatric primary care clinicians to understand how early adversity can affect health. And one of the things that I think is really powerful about that is I believe that just this knowledge, just the understanding, and particularly when it's presented by a physician or a primary care clinician, that education in and of itself is really powerful. And a lot of folks, you know, wonder, like, what can we do, how can we screen if we don't have, you know, full integrated care or, you know, or even mental health that's easy to access. And I think that so many parents simply don't know that early adversity can affect their kids' health. They think that kids will forget, or if they're little, they don't know what's going on, and they don't recognize that the experience of adversity affects their child's biology. And I think that's something that's really important for us to be able to communicate.
Great, thank you for that answer, Nadine. Our second question touches on the resilience piece of a trauma-informed approach, and an often overlooked piece. So one of our participants asks, how do you use, or do you use a resilience tool to measure resilience? And if not, how do you incorporate resilience into the conversation with a patient or family?
So when we do the ACE screening, when I'm talking to patients about these issues, I ask, so I ask them about the 6 factors that I talked about in this talk: sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships. And I actually ask my patients, okay, so how do you kind of rate yourselves in each of these categories? And it gives them an opportunity to say, oh, sleep, we're doing fantastic there. Great, that's so important. I get to reinforce that and take a strengths-based approach to what we're doing well. We don't use a resilience screen, and the reason we don't do that is because, so you'll notice in this example, so we don't use it in the primary care environment. In our multidisciplinary care, our mental health clinicians do assess for strengths and what folks are often referring to as resilience factors. My challenge there is that I think that we often, when a patient has no behavioral symptomatology, right, and in this case, the presenting symptom was poor growth, I think the factors that folks are currently using as resilience factors have not been assessed against, for example, the normalization of functioning of, for example, the hormonal, the endocrine system, or the immune system, or the epigenetic regulation. And so that's, I think most of them come out of the mental and behavioral health field, which I think is really important. We are trying to do this multidisciplinary work. But my worry is that we often will suggest that someone is resilient because they're doing well behaviorally when their physiology may be greatly impacted. And so we're trying to update our tools for assessing resilience based on this understanding of the pathophysiology of toxic stress.
Thank you for that answer as well, Nadine. You've touched on this a couple of times throughout your presentation so far, but we've gotten a couple of questions about the relationship between the Center for Youth Wellness and the Bayview Child Health Center. Could you please say a few more words about the nature of each organization and how they work together to serve your patient population?
Absolutely. So the Bayview Child Health Center is a primary care pediatric clinic, and it's part of a federally qualified health center here in San Francisco. And that is the place where we do routine screening for adverse childhood experiences. Part of the reason that we do the routine screening there is because we understand that number one, the manifestation of toxic stress can take a lot of different forms, and sometimes it's behavioral, but sometimes it's not. Sometimes it's asthma, sometimes it's altered pubertal changes with puberty. So it could be a lot of different things. So screening in primary care is absolutely critical. The other piece is that our ideal goal is to interrupt the progression from early adversity to poor outcomes, whether they're behavioral outcomes or mental health outcomes or health outcomes. So that's the other reason that we're trying to do this in primary care. And then the Center for Youth Wellness really provides the wraparound services that are focused on addressing the impacts of early adversity. So we do integrated, as I mentioned, integrated primary care and behavioral health. Our team at Center for Youth Wellness does home visits, health education, biofeedback and neurofeedback. We do, work on nutrition, mindfulness, all of these different pieces. And so essentially the screening happens in the primary care home, and then there's some type of referral that happens to the Center for Youth Wellness where patients get this multidisciplinary care. There's a couple of approaches that we take that I think are really important. So one is we do team-based care. Once a week we all get together and have something called multidisciplinary rounds, where we talk about all of the patients that are being referred from the Baby Child Health Center to the Center for Youth Wellness and talk about their presentation, what we think the issue is, and what we're trying to accomplish in terms of treatment goals. So that's one piece. And then in addition to that, as I mentioned, the integrated care. Now, Center for Youth Wellness has some other things going on. So in addition to our clinical services, we also do research work to help to advance the science, and we also do some movement building work because our focus is really on understanding how we can change the way primary care and also our society in general responds to the issue of childhood adversity. But those are, that's kind of, how we work together for comprehensive patient care.
Great, thank you very much for that as well. I have a two-part question for our next one. I guess the lead into the first part of the question is that we have heard a lot in our work about physicians, specifically physician apprehension to implementing ACEs screening and adopting a trauma-informed approach. One of the common barriers we've heard physicians cite to implementing this approach is just a lack of time to do the screening and a lack of comfort to do the screening. I was hoping you could talk a little bit about how to develop physician buy-in and also how to implement screening into the clinical workflow, given the short amount of time you have with patients.
Absolutely. So that is actually a big part of the reason why we developed a de-identified screen, because we understand in primary care, like we want to understand primary care clinicians are typically, what we're good at is identifying when there's a problem and then connecting families to, if it requires more specialized care, connecting families to that care. And what we found, the reason we moved to the de-identified screen was that, frankly, our primary care clinicians didn't have the time or the training to be asking some of these questions and particularly unpacking them skillfully. Now, one of the reasons why it's so important to screen in primary care is because primary care clinicians have this incredible relationship, this long-term relationship with their patients. But at the same time, even though that relationship is so important, when you're talking about unpacking physical, emotional, and sexual abuse, right, or neglect, or a household member who's mentally ill or substance dependent, there's a lot of skill with that. So, for example, in the patient that I talked about with the case presentation, it took, I think, 4 one-hour sessions for our mental health clinician to go through and really unpack all the pieces in terms of this patient's history of adversity. And I, as the primary care clinician, I still don't know what her 7 ACEs are. I will tell you, I still don't know. But in talking and doing and co-managing this patient with the mental health clinician, what he did, we were able to discuss, you know, how this was playing out in terms of how it was impacting her health and her growth. In order to be able to screen every patient, it can't take me an hour to do it. Like my visits are 15 minutes, and that's why we have this de-identified screen that tells me the score is 0, great, I know what to do with that. The score is a 4, or this patient is having symptoms, I also know what to do with that, and I know how to connect them with services, and that's what primary care clinicians are really good at, right? And that screening process honestly takes us like 3 minutes or less to go through and review it and explain to, you know, walk through the script that we have around talking to parents about why we're screening, what the implications are on health, and then what the next steps are. So I think that makes a big difference.
Great, thank you. One last question that we have time for during this Q&A session. What advice would you give primary care providers who are looking to take initial steps toward becoming trauma-informed?
Yeah, so I have one tiny addition to the last question, which is also primary care clinicians need to understand the relevance to their practice, and that's why the case example that I gave was a case example of a patient who didn't have any behavioral concerns or any developmental issues, right, that she just wasn't growing. And in order for doctors to do their job, they have to know, they need to know that her ACE score could be a factor in why she's not growing, right? And that's squarely in the primary care clinician's, you know, realm. In terms of what's important for doctors to understand, or primary care clinicians to be able to understand when they're thinking about screening, well, you know, one thing I think that's really important is an understanding of that implementing ACE screening is not just a, you know, you're adding one more like screening tool to your 10 screening tools that you're doing. It does involve some practice change, as anything that if we want to do it effectively in practice requires getting the practice on board to understand how to do it, why we're doing it, and what are some of the best practices. So I do really recommend that folks, as they're thinking about implementing this, really review the importance of having, you know, trauma-informed systems in the primary care home, just as you would, you know, making sure that everyone in the office gets their flu shot every year and has their TB test every, you know, whatever it is, period of time, or that we all know universal precaution, or we all know if a kid comes in with a rash, they got to, you know, wait somewhere else and not be with all the other kids in the waiting room. Everyone in the practice has to know that, and everyone in the practice has to know about trauma-informed care, and I think that it's just a basic part of medical care. I think right now we're kind of seeing it as an add-on or a bonus, and I don't see it that way. I see it as fundamental to our practice, because so many of the folks walking through our doors, right, we're talking about, you know, 2/3 of individuals have at least one ACE. So if our program is not if our practice is not trauma-informed, it's like not washing your hands after you see a patient, right? For me, that's what I would say is really getting some of these trauma-informed principles throughout the practice, I think, is critically important.
Great, thanks so much, Nadine, both for your really informative presentation and the very comprehensive answers to all of our participants' questions. As you might expect, we received a great deal of questions for Dr. Burke-Harris, so we'll be posting answers to those questions and answers to those questions on our website following today's webinar, so be on the lookout for that. Thank you once again. And at this point, I'd like to turn it over to Dr. Eddie Mochtinger, who's going to talk about implementing a trauma-informed care approach in an adult primary care setting. Eddie, it's all yours.
Thank you so much, Chris. My name is Eddie Mochtinger. As Chris said, I'm a professor of medicine, and I direct the Women's HIV program at UCSF. I'd first like to also thank CHCS and the Robert Wood Johnson Foundation for really becoming national leaders on this issue. It's also an honor to present today with Nadine, who has done this amazing job galvanizing the country to respond to ACEs, and to be talking with all of you. I really wish I could see you and meet each of you. It's a little weird to be presenting not looking at you. So my plan today is to briefly discuss how we developed a practical model of trauma-informed primary care for adults in our clinic and describe the solutions to the many challenges we encountered along the way. I'll end with practical steps that any clinic or clinician can take to move towards practicing with a more trauma-informed approach, and leave ample time for questions. I'd like to first acknowledge our UCSF team and community partners who have been crucial to implement and study this new model of care. So the Women's HIV Program, WHP, where I work, was among the first programs in the country specifically designed for women living with HIV. Our clinic is partially supported by congressional Ryan White funding for clinics caring for low-income individuals with HIV. And this national network cares for approximately 600,000 of the 1.2 million people living with HIV across the country. And I say this because this funding allows our clinic, possibly more so than many of the ones you practice in, to provide on-site interdisciplinary services, including primary medical care, gynecology, obstetrics, a pharmacist, social work and case management services, therapy and psychiatry, linkages to substance abuse treatment, and a communal breakfast during each clinic with patients and staff. Most of our patients are women of color, inclusive of transgender women. They're low income and face multiple concurrent health and psychosocial challenges. So before I advance to the next slide, allow me to pause for a moment to share an important realization we had about our supposedly excellent clinic. So in our program, over 85% of women are on HIV medications. And of those, over 85% have an undetectable virus in their blood. And these rates are far higher than national averages. And because of this, we receive many commendations, and our model of care is considered the national standard for this population. But if you scratch a little beneath the surface, you come to see that 40% of our patients are using hard drugs like heroin or methamphetamine or crack cocaine. 50% of our patients report being depressed. Very few patients are out about their HIV status or history of trauma, which makes it really hard for them to make real friends and form supportive relationships. Many are living with abusive partners, very few are working, and far too many are dying from an array of preventable illnesses. In 2010, 7 years ago, our program was awakened to this disconnect between taking good care of the virus, but not actually providing effective care of the person, when one of my most beloved patients was murdered by her husband. And Rose, who's the first person on this list, was a soft-spoken, 53-year-old African-American, incredibly kind woman who came to our clinic in the midst of crack addiction, and she was experiencing vicious intimate partner violence from her husband. And despite trying our best to protect her, he lured her away from where she was hiding and murdered her, likely because he knew that this time she was really trying to leave him. And after any patient dies in our program, we convene the entire team to discuss what happened, to mourn her loss, and to try to learn from it. And looking at 10 recent deaths, 2 were from murder, 3 were from suicide, One was from an addiction-related accidental overdose. One was from addiction-related multi-organ failure. One was from addiction-related lung failure. One was from pancreatic cancer. And one was a 22-year-old young woman who I met when she was 15 years old when she was initially diagnosed, who stopped her HIV antiretroviral medications because she was just totally isolated and hopeless and ended up dying of a completely preventable brain infection called PML a year after she delivered her first baby. And we knew these women really well, and they were all really very different. But their stories are united by all having lifelong histories of trauma that contributed to their being infected in the first place with HIV and led directly to their deaths in the cases of Rose and Amy, and indirectly through substance abuse, depression, and hopelessness in most of the others. So 7 years ago, after Rose was murdered, we convened a citywide meeting of the many agencies and individuals who worked with her and loved her to learn from what happened. And the group concluded that our clinic, and really our whole primary care system, was unprepared for the danger she faced. And just as important, really didn't have the services designed to help her heal from the serial abuse she had sustained over her lifetime and gain the self-efficacy and social support to avoid this guy or leave him a long time ago. And we committed ourselves to changing our clinic to one that was more responsive to the actual needs of our patients. We partnered with the Positive Women's Network USA, an amazing organization, the largest advocacy organization in the country led by and for women living with HIV. And we looked for ways to address trauma in a clinic setting and found that there was a lack of guidance at that time for a clinic director like me about the core components of a practical approach to trauma-informed primary care. And so together, we convened a working group of 27 leading national policymakers, trauma experts, and advocates from the government, from the military, academia, clinics, community organizations, and women living with a history of HIV and trauma themselves to identify evidence-based building blocks of a practical model of trauma-informed primary care that addresses both intimate partner violence and lifelong abuse, and has a strong emphasis on provider well-being. Now I'm going to briefly describe each component of that model. So the model we developed has 4 core components. It's vastly oversimplified. But for me, this was the type of guidance that I was seeking when I first sought out to develop a trauma-informed primary care clinic. The first component is a trauma-informed environment that is calm, safe, and empowering for both patients and staff. So previously, many of us thought that a frontline poverty medicine clinic by nature is chaotic. And many of us, me included, actually sought out that chaos, possibly because of our own traumatic experiences. We came to realize, though, that this was the opposite of the calm environment that we needed to care for ourselves and for our patients. And as a first step to create a calmer environment, providers and staff from every discipline were educated about the impact of trauma on health and ways to communicate with patients and with each other that are less triggering and more calming. The second core component is screening, or we would rather say education and inquiry if we had to redo this graphic. Providers routinely inquire about both current violence and the consequences of lifelong abuse, including PTSD, depression, and substance use. Providers consider whether to inquire about the details of past abuse in the course of their relationship with each individual patient. And I think it's important to note that intimate partner violence and other trauma-related conditions are often experienced as shameful by patients. And thus, we should not depend on positive screens to provide education to everyone and referrals to service. And finally, patients are directly linked to on-site and community-based interventions that promote safety and healing from current and lifelong abuse. And all of this is based upon a foundation of trauma-informed values that Chris described in his introduction, and sustained institutional or at least clinic support for providers and staff, many of whom, not coincidentally, have experienced trauma themselves and often experience vicarious trauma from working with a highly traumatized population. So I'd like to pause a moment again before my next slide and be a little bit more specific about these responses, because the graphic is so simplified in this regard and most people want to better understand what they can do. So it's important to know that there are many evidence-based practical interventions and strategies that can be integrated into busy primary care clinics to help people become more safe in the face of intimate partner violence and to heal from the impacts of lifelong trauma. It's not necessary for us as individuals to relive people's childhoods, because we can't, or for us to eliminate racism or stop our government from terrorizing immigrant communities in order for us to meaningfully address childhood trauma and structural violence. As clinicians in primary care clinics, we can still, from our vantage point in the clinic, still meaningfully address these issues by helping our patients heal from past abuse and cope more healthfully with the impacts of ongoing trauma and structural violence. So, for example, responding to intimate partner violence, once it's identified, includes creating a safety plan using one of many available tools found online, assessing the degree of immediate danger using the danger assessment tool, for example, developed by an amazing researcher named Jackie Campbell at Johns Hopkins, which is also found online, or more commonly by linking that patient in real time to a domestic violence agency in the community who can partner with you to do this or even take over completely. We've also found that prompts and standardized documentation, including scripts of how to ask these questions and how to respond, integrated into our EMR are very helpful. And then it's important to have some mechanism in clinic to stay aware of the active DV cases that you've identified to ensure that such individuals continue to receive attention and support, like bringing them up at quarterly meetings. So this is a bit more complicated, but in practice, incredibly fulfilling. To heal from the impacts of lifetime trauma, the interventions that we are incrementally integrating into our clinic are based on our observation that ACEs and trauma as an adult rupture three types of connections. First, trauma ruptures connections with other people. Many people who have experienced trauma often have a hard time with relationships and feeling safe and open with other people. Oftentimes because the very person who is charged with keeping them safe and with loving them was the person who neglected them or hurt them most deeply. There are many interventions that can help repair connections with others, and these include, in general, trauma-specific individual and group therapies and peer-led support and empowerment groups. Second, trauma, especially childhood trauma, ruptures physiological connections. And Nadine so eloquently described the way this happens in her presentation, so I won't repeat that. But repairing these damaged physiological connections and coping better with them can happen in many ways, including with trauma-specific psychiatry, using medications, for example, to handle triggers and anxiety or nightmares, or physiological techniques such as EMDR. And third, trauma profoundly ruptures connections with our own bodies, leading to shame and chronic pain, and often making intimate relationships really difficult. Repairing damaged connections with our own bodies can occur through a variety of body and mindfulness-focused treatments like massage, yoga, and mindfulness-based stress reduction. So true healing that we've seen often requires repairing each of these connections, but can happen gradually over time according to what an individual is ready for and interested in. And I present this slide not because I expect clinics to offer all of these therapies right away, which is impossible. But clinics making the transition to trauma-informed primary care can identify resources they have already in clinic or in their community to decide which interventions make the most sense for their clinic and for their patients. And we can talk more about specific interventions if you're interested in the Q&A after this talk. I describe these interventions mostly right now because I want to express that I've seen them help people heal from even the deepest wounds of trauma when they get evidence-based treatment for it. Patients who have gone from being addicted to opiates and homeless, really considered by many to be lost causes, to regain their health, to get housed, to recover from addiction, and be reunited with their children. And Nadine spoke so eloquently about helping children heal. And I can't think of a better intervention for children's well-being, for child's well-being, than to help a mom overcome opiate addiction or avoid going to jail or avoid dying. So I'd like to end my part of the presentation with a few lessons that we've learned as we've implemented trauma-informed primary care over the past 5 years. The first is that it's, like Nadine mentioned, it's very helpful to start by educating everyone in the clinic about the impact of trauma on health and behavior, to demystify why some people act the way they do, and why some health conditions are stubbornly refractory to traditional medical treatments. And in that education, to learn ways to interact in a more healing way with patients and with each other. We also formed partnerships with organizations in the community to help us not be so isolated in our efforts. For example, through CHCS and the Robert Wood Johnson, we are participating in this learning community and obtained a grant to establish a collaboration with the Trauma Recovery Center, who has now mentored our existing social workers on how to deliver STARE, which is a highly effective group therapy for PTSD. We also started transforming our waiting area into a calmer space. And this picture on the right is of Pepper, one of our therapy dogs that is with us every clinic, interacting with both our patients and staff. Something, this is in the next slide, something that I want to show you that I found crucial to our effort, really the foundation of it, for me and I think for others, is to make time for an interdisciplinary meeting prior to every clinic, even a short one. Now, ostensibly, this meeting is to coordinate care and the logistics for the pending clinic, but really the purpose it serves is to unburden individual clinicians with the weight of holding so many intense patient situations, really their fear of a patient dying and they're not adequately responding to that risk. It also helps to create community and respect among all types of providers and community partners. As we, on the next slide here, as we began to offer more services, it became clear that we needed to develop a team composed of psychosocial providers who can match patients with the most appropriate services. For patients, this ensured that they were matched with services that they were ready for. For example, it didn't work when we started trauma therapy with an isolated woman addicted to crack cocaine. What she needed instead was a general support group that focused on reducing isolation and receiving harm reduction. And this realization reflected our own gradual understanding of the phases of trauma treatment. This team also empowers the psychosocial providers themselves to make key treatment decisions, and it helps flatten the traditional medical hierarchy in our clinic and common in so many other clinics. Next is that trauma-informed care is predicated upon having patient voice and choice, meaningfully guide key decisions. But doing so is often really unfamiliar and hard to realize in the midst of our own really stressful work lives. So we asked our primary community partner, the Positive Women's Network, to lead focus groups with our patients to better understand how they would like to get involved. And what emerged are regular stakeholder meetings where individual representatives of each discipline in our clinic, and then 4 patients who apply for 6-month terms and are compensated for their time, meet once each month for 90 minutes to get input from everyone before we introduce any new intervention or change in the clinic. We purposely select representative patients who may themselves be struggling with the impacts of trauma, but they have been incredibly engaged, and their participation with all of the staff and clinicians has been really meaningful, both in practical ways, but in more intangible ways. So it's really inspirational for me and transformative to be in a room with every type of staff person and a number of patients discussing how to best run this program. And this is not how traditional medical clinics have been run or our clinic used to run. And how radical it feels, I think, shows how disconnected most clinics are from the actual priorities of their patients. And lastly, it's hard to overemphasize the role that substance abuse plays in the well-being or lack thereof in many of our patients. It is clear from our experience and from the literature that substance use treatment is far more effective if the trauma and PTSD that underlie and perpetuate it is also addressed. As we rolled out different therapies for trauma, it became clear that many patients who were using drugs were unable to engage in these treatments. And then some of the patients who did engage relapsed, likely as a result of dealing with feelings that emerged. So we're so excited to have just received a grant from SAMHSA to integrate substance use treatment, including medication-assisted treatment and individual substance use counseling, in a staged-based way coupled with our treatments for trauma. And I'm so excited about this. I strongly believe that this model, integrated substance use and trauma treatment, will be the most effective method to help people overcome opiate addiction and other addiction in the outpatient setting. So it's important to know that this model is totally aspirational and should serve as guidance more than a prescription. Most of us are not fully in control of our clinical environment, and this approach can and likely should be incrementally implemented. So what can you do tomorrow? So you can realize that a lot about who we are and what we do are because of things that happen to us, and that's the same for our patients. You can embrace trauma-informed values for yourself in whatever ways that you control and in your domains. You can distribute literature in the waiting room about the impact of trauma and health, demonstrating your own and your clinic's commitment to this issue. You can arrange for trainings, and there's many trainings, good trainings now available, and ideally for the whole clinic or for a number of people in the clinic, about the impact of trauma and health, about developing trauma-informed skills to use with each other and patients, and for screening for IPV and the impacts of lifelong trauma. And ideally, you can assemble a team, even if it's just with one other person, that is interested in this issue to get educated, collaborate on steps forward, and support one another in the process. And over time, a clinic champion can emerge, protocols for screening can be made, and responses to IPV and lifetime trauma can be developed or identified in the community in partnerships with local organizations and other like-minded practitioners. Now, this isn't easy, but it's doable, and there's now excellent guidance from CHCS, from SAMHSA, and others about how to realize each of these steps depending on your clinic resources and your clinic population. So in conclusion, people can heal. Deep cycles of violence can be broken. ACEs in children can be reduced, and entire communities can benefit by addressing trauma in adults. And the problems faced by most of our patients can be more effectively treated if primary care becomes genuinely trauma-informed. And trauma-informed primary care holds the potential to transform the caregiving experience of providers, creating environments and supporting them to move from being treaters to being genuine healers. thank you so much for participating today.
Thank you, Eddie, for that great presentation, and thanks so much for just sharing the great work that your clinic is doing with the patients that it serves. So we'll now hold a 15-minute Q&A session with Eddie, and just another reminder to submit a question, please click the question mark icon located in the toolbar at the top of your screen. So our first question to Eddie: what advice would you give to physicians working with an adult population that is not classified as particularly vulnerable or at risk? And what advice specifically would you give to providers who don't see ACEs as relevant to that population? Are there any resources you could recommend sharing with them?
I think it's interesting because Nadine mentioned screening for ACEs in children, and in my presentation I didn't highlight screening for ACEs in adults because I work in a setting that is an HIV clinic, and HIV, like substance use, obesity, mental illness, diabetes, and so many other diseases are markers for ACEs. And I don't, I tend to use a universal approach towards dealing with trauma, and so I assume that people with these conditions have a high ACE score and don't tend to prioritize screening for ACEs. But for clinicians who aren't aware of the prevalence of ACEs in their population and who might believe that their population, because like the population Vince Leddy studied, is predominantly white or upper middle class or working or insured, that they might not have ACEs, I think that is an excellent opportunity to screen for ACEs so that people can recognize that indeed their population, whomever they're working with, actually has a high rate of ACEs, and that many of the conditions that they're working with, inevitably common in primary care, depression, obesity, anxiety, are indeed related to ACEs and adult trauma and would benefit from a trauma-informed approach. And I guess lastly, I'd say primary care is a really stressed endeavor these days. I cannot imagine almost any primary care clinician or staff member describing their clinic as calm, or that their job is being in many ways fulfilling. The best and the brightest right now don't go into primary care because of that. And I think trauma-informed primary care gives us the opportunity to get involved in the issues that are the real determinants of health in this country, and allows us to be healers in a way that we're principally treaters, giving people medications and procedures and not really dealing with what is underlying most of their illnesses. So I'd say to that person, take the temperature of their primary care clinic and ask how people are doing and feeling. And if they're not really thriving, consider trauma-informed primary care as a way to transform the caregiving experience as well as the care receiving experience.
Great, thank you very much for that, Eddie. Another question we just received: how do you measure effective trauma-informed care? And I would just add, if you could talk about that possibly on the patient impact side and also on the staff side too, that would be great.
So we're doing a formal, part of our role in the world is to demonstrate this on behalf of our patients at the Women's HIV program, but also to do a formal prospective evaluation of the impact of this new model of care on both our patients and our providers. And we're doing and have done a comprehensive mixed methods baseline study of all of our patients, or the majority of our patients who have signed up for the study, and the vast majority of our providers. And we're measuring everything from empowerment and resilience to substance use and PTSD symptoms to other biological markers like viral load. And so from a research angle, we're measuring a lot of things to determine which elements of our model are successful. From a clinical standpoint, I would say that the observations and experiences of the staff are going to rule the day. So, for instance, we started a new relationship with the Trauma Recovery Center where we could refer our patients there for PTSD therapy. But no one went, or very few people went, and the people who went were really not the most appropriate referrals to that agency. And we had to reconvene and realize that the services that we were offering were not actually acceptable to the patients. They wanted services here on site, and we had to retool our whole initial plan with the Trauma Recovery Center to move those services here on site. So I think the first way of assessing things are what services are actually acceptable and attended by patients on a regular basis with limited dropout rates. And then I think the other things are anecdotal, like which services seem to help the clinic be a more calm place and help the waiting room feel like it's a refuge and like it's safe and in a place that you as a provider want to be. And which patients who you previously thought were stuck in their addiction or in their diabetes management, which patients have become unstuck and seem to be benefiting from understanding that their illness is linked to their past trauma and in a stage-based way are getting help dealing with that and overcoming that, and thus having their illnesses be more effectively managed. I could go into much greater detail about the measures that we're using in our study, but I think I would use up the rest of the time doing so.
Great, thank you. I think that was a nice overview. So our next question surrounds staff trauma and vicarious trauma. Can you talk a little bit about what measures you put in place to protect your staff from vicarious trauma and promote self-care?
Yeah, and again, I'd like to say that people seeking out work with traumatized patients, people who want to work in HIV programs, want to work in substance use programs, it's not a huge coincidence that many of us have had trauma. That motivates our compassion and motivates our own interest in self-healing and trying to transform our self-healing into a focus of healing others. And so we really need to be careful with our staff and providers, and then also acknowledge that the burdens, and there's so many examples where who I think I'm so experienced doing this now, get overwhelmed hearing every so often something really breaks through and overwhelms me in terms of hearing a traumatic story. And so we really have to support our staff. And I think what I brought up initially is that the main healing, or the principal foundational healing tool we have for our patients is reduction of isolation. So many people who have HIV or trauma are not out, haven't told anybody about their isolation. And I was a gay kid. I wasn't out as a gay kid. And I know where you go, what a dark place you can go to when you really can't share your life with a friend or an adult or a parent. And so that same reduction in isolation that we're focused on with our patients is how I believe we're best going to support our staff and providers to not get so triggered in terms of their own trauma and with vicarious trauma. And so what we have, and I mentioned this, is we have meetings that help our providers and our staff voice concerns about the patients they're taking care of, about incidents that they've witnessed, so they're not bearing all of that on their own. And I think that is the single most important staff well-being and vicarious trauma intervention that we currently have. We have many others. We have a masseuse in clinic that actually helps the staff as well. Pepper the dog, honestly, is probably more for me than anyone else in clinic. And there's other seminars that we've had and teaching and educational seminars that specifically help our staff deal with vicarious trauma and their own reaction to trauma. But I think it's the group, it's the team, it's not doing this alone that is the key intervention.
Great, thank you for that as well, Eddie. You touched on this briefly in your presentation, but we got a question around how can trauma-informed care fit into addressing the opioid epidemic?
Oh, I'm so interested in this. The opioid epidemic is epic, and it's really captured the attention of the whole country. And this is, people say it's because it's now affecting white people, but it affects everyone. It affects Black people and brown people just as much. And I see a lot of groups and conferences focused on elements of a response to the opioid epidemic. In particular, I see people talking about the overprescription of medications by physicians, about the role of pharmaceutical companies, and a lot of people are focusing on medication-assisted treatment, and I think all of that is both true and helpful. But I think it really misses the truth of what underlies most of this opiate addiction in the country, which is trauma, which is ACEs, and this is very well studied, and this is an ongoing trauma and structural violence as an adult, the despair, the racism, the sexism, the homophobia and transphobia, the terror and the fear in the immigrant communities that needs to be addressed concurrently with substance abuse treatment in order to be effective. And there are, interestingly, to address substance abuse, there's stages of change, pre-contemplation, contemplation, preparation, action, and maintenance that we're all aware of. But these are almost identical to the phases of trauma treatment, which is engagement and behavioral and safety treatments, and then more intensive trauma treatments, and then reintegration and empowerment. And it's the marrying of these two epidemics, treatments for these epidemics, substance use and trauma, that I believe will have the greatest impact, and research has already shown will be far more effective than addressing either of them in isolation.
Thank you for that, Eddie. One more question. What are some practical ways to improve the physical environment of a healthcare setting?
Well, first, I'll just say I was just up in Vancouver in a mobile ICU that they have in a truck in their version of our Tenderloin, which is where most of their fentanyl overdose is occurring. And someone said something very meaningful to me, which was, they said, look, this ICU doesn't look anything like a trauma-informed clinic. There's no fish tanks. There's no, calming colors. And what they said was that their patients, though, really appreciated having access to absolute state-of-the-art services and to be treated with respect and with dignity and not be judged for their substance use and for their overdose. And so I think there are ways to create an environment that's more calm, that is more, that facilitates community and privacy through having, a support animal, to having breakfast where people can form community, to having a masseuse in clinic, which really makes a big difference with my patients who are really anxious and who have PTSD. But I think it's the quality of the services, it's the respect shown to people from the staff and the providers, it's the lack of judgment that people have. It's when someone comes in and they're high on crack and they've made it to clinic to say something really nice to them, regardless of whatever else happens that day, to say, hey, that's a really awesome backpack you have. Where did you get that? And thanks so much for coming today. That must have been really hard for you. That is so much more important than concrete, changes to the physical environment.
Great. Thank you very much for that answer as well, Eddie. We have time for just one more question, and I'd actually like to address this to both Nadine and Eddie. And I'll preface the question by saying that given how closely we've worked with you both over the past few years, we understand that you both have kind of a mix of grant funding. But we've gotten a lot of questions around payment. So the question is, how can payers better support trauma-informed care work? I'd like to bring Nadine back in maybe first to take a crack at this, and then have Eddie go after that.
Yeah, there is so much that payers can do. I mean, and a lot of it has to do with creating reimbursement systems to support, integrated primary care and behavioral health, or to support team-based care and reimburse for that. We know that there are quite a number of states now that are putting forth legislation to be able to support some of the basic billing and healthcare infrastructure that allows payment for these types of interventions. I think that one of the things that's really tricky, so for example, here in California, there was a bill that was proposed to allow a patient on Medicaid to be able to see a primary care clinician and a mental health specialist on the same day, right? It was both of those services are already covered in with Medicaid here in California, but for some reason there is a provision in the law that says they can't happen on the same day. So leaders in California put forth legislation to allow that, which essentially allows integrated primary care and behavioral health. And unfortunately, it was vetoed by Governor Brown. But those types of ways to support the infrastructure to allow this type of work to happen, I think, is critically important.
And I'll just say, I have so much to say about the cost, but I'll say very briefly, there's a lot of money now being spent on high-cost, high-need patients, investments into that group of people, into the opioid epidemic, into responding to the mandates of accountable care organizations that now prioritize health instead of procedures and hospitalizations. And it's still surprising to me how little awareness there is around trauma and around evidence-based interventions for trauma-informed primary care as a lattice for an approach to people addicted to opiates and the high-cost, high-need patients. And so my advocacy would be to make sure that the money being spent on those populations and on these efforts be tied to this evidence-based, deeply evidence-based lattice around addressing trauma as the most effective entrance, both from the perspective of efficacy with the patient, but also from the perspective of the well-being and experience of healing of the provider.
Thank you very much, Nadine and Eddie, for those thoughtful responses. So we're just about out of time, but before we close today, I want to remind everyone about the second webinar in our two-part series. On October 30th from 12:30 to 2 p.m. Eastern, we'll hear from Ken Epstein from the San Francisco Department of Public Health, who will be discussing how to build a trauma-informed organizational culture. We'll also hear from Rahil Briggs from the Montefiore Medical Group, who will be talking about implementing a trauma-informed approach across a large health system. I'd also like to invite everyone to visit chcs.org/trauma-informed care to learn more about the Advancing Trauma-Informed Care Initiative, to download practical resources for adopting trauma-informed approaches to care, and also to subscribe to CHCS's email and social media updates to learn about new programs and resources. So before closing, I just want to extend a huge thank you both to Dr. Nadine Burke-Harris and Dr. Eddie Mochtinger, again, for their wonderful presentations today. I also want to thank all of our participants for joining us and for submitting so many thoughtful questions. Again, we'll be posting kind of an overflow Q&A on our website in the near future, so please be on the lookout for that. And thank you, of course, to the Robert Wood Johnson Foundation for supporting our webinar today and the Advancing Trauma-Informed Care Initiative overall. Thank you, and we hope to see you again on October 30th. Have a great rest of the day.